We're going to be talking about the workforce in behavioral health. We'll be discussing some of the challenges, but along the way I'll also be sharing with you some of what I believe are some of the most innovative solutions to the workforce crisis in the mental health field. This is a picture of the cover of the New York Times Magazine from 2003. The picture is meant to depict a medicinal leech on the back of a woman. Medicinal leeches were used in plastic surgery until very recently. And the quote at the bottom of the cover is half of a famous quote from a medical educator. And he said, "Half of what doctors know is wrong. The problem is we don't know which half." This represents an area of public concern that emerged around the turn of the century, which was concern that healthcare providers were not fully competent, that healthcare practices could be dangerous. And it really sort of marked the beginning of an era in which there was much more focus in looking at the quality of care, including the quality of mental health. A second stream of findings that I'd like to tell you a little bit about is this accidental finding that came from a study of substance use disorder treatment. Dr. McClellan, Tom McClellan, a famous researcher in the substance abuse area, was looking at quality of care in substance abuse treatment organizations over a period of 16 months. And his method was to come in and interview directors and staff, and to come back a little over a year later to look at how, if at all, quality had changed. But the surprise finding for him, and the accidental finding, is that when he came back 16 months later, basically half of all the directors of these agencies and half of the counselors in these agencies had left. And he began to write about and talk about the fact that if we did not have stability in our behavioral health organizations, that it was going to be very hard for us, if we did not have stability of workforce, it would be very hard for us to really sustain and improve quality of care. Things are actually much more challenging right now for the behavioral health field for a very simple reason, which is the economy in the United States is very, very strong. There are now more open jobs across the entire economy, not just behavioral health, than there are unemployed Americans, which makes it a great economy for people who are looking for jobs or looking to change jobs. What this also means is that the quits rate, which is the frequency with which people are quitting their jobs and taking other jobs, is the highest it's been in almost 20 years. And we see this now in mental health and addictions, a very significant sort of churning of the workforce, with greater turnover rates and people looking to take other opportunities. So these are the challenges that we've have faced for a long time and are really acute for us, which are first making sure that our workforce that we have is competent and providing quality of care. And the second is to make sure that we have sufficient numbers in the workforce and can work to retain them in the workforce. So my colleagues and I, about 20 years ago, created the Annapolis Coalition on the behavioral health workforce as a vehicle for bringing together people from all professions and all parts of the mental health and addictions fields to look at the growing workforce crisis, to provide technical assistance on understanding these problems, and also disseminating information about best practices on how to deal with the workforce crisis. We developed for SAMHSA a national action plan for the nation. And out of this national action plan emerged something called the Annapolis Framework, which is a framework or conceptual model for understanding the workforce crisis and areas of intervention. And it's made up of 9 different objectives that are organized into 3 very broad categories. The first of which is to really think more broadly about the concept of workforce and who's in the workforce. The second is to strengthen what we think of as the traditional workforce. And the third category of objectives has to do with building structures to better support the workforce. And what I'd like to do for you is sort of walk through the 9 goals and share with you the opportunities that we have in the behavioral health field to strengthen the workforce in these various ways. Before doing that, I want to just comment on the nature of the data that's available on workforce evidence-based practices or best practices. The data is variable depending on the topic in its amount and its quality, and some of it is not very rigorous, so there are questions about its validity. We mostly have survey data and qualitative and anecdotal data around workforce interventions, and unfortunately some of the data becomes quite dated very quickly sort of after it's released. So you could be sort of negative about what we have and say the formal evidence base on workforce practices is limited, but I would argue that there's actually a very large and valuable literature on best practices, and that most of the world, healthcare and in business, relies on best practices that have been identified over the generations in thinking about how we recruit and retain and develop the workforce that we have. So let's move forward and look at some of these objectives and some of the innovations within them. So in thinking about broadening our concept of workforce, the notion here is that we will never have enough professionals coming out of our traditional disciplines to meet the needs for mental health care in the United States. And expanding workforce roles for persons in recovery and families, we view as perhaps the most important #1 sort of priority as we move forward in developing our service systems and the workforce within it. The specific objectives that have emerged in this area are to first educate people in recovery and families about self-care. The second is to build their competence in shared decision-making, having them be much more engaged in making decisions about the type of healthcare that they want. The third area here is to expand peer and family support services, both formal, organized efforts as well as informal support mechanisms. The next is to increase the employment of people in recovery and their family members as paid staff in our systems. And the last and sort of very innovative area is increasing the use of people in recovery and family members as trainers of what we think of as the more traditional workforce. I would argue that peer support, the development of peer support workers is the most profound change that we've seen in the mental health workforce over the last 20 years. And there have been enormous developments, and there are a wide range of resources available to you to help in this endeavor. There are multiple competency sets that have been developed. There are formal curricula and training programs, certification processes for peer support workers, and there are reimbursement mechanisms for the time of peer support workers, which makes it particularly viable intervention in our systems of care. These things have all led to a number of pressing issues that are before us now. We continue to struggle as a field with defining the role of peer support workers in our systems, of gaining their acceptance by others that were already working in these systems and bringing about change in organizational culture that supports peer workers being in these service settings. People are beginning to develop models for supervising peer support workers and addressing questions around who should supervise peer support workers and what the focus of supervision should be in an intervention that involves primarily the provision of peer support. We have questions before us about career development advancement for peer support workers because we've created frontline peer support positions, but there are not a lot of opportunities for people to grow through a formal career ladder and advance in these roles. And lastly, we're beginning to see turnover as peer support workers leave these positions. And so retention is something that becomes paramount for us to think about as well. I've highlighted here the Yale Program for Recovery and Community Health, based here at Yale under the leadership of Dr. Larry Davidson, who's been a primary leader in this area and also runs one of the mental health technology transfer centers. They have created a wealth of resources for not only training individual peer workers, but also for making entire systems of care and organizations much more recovery oriented. And I would encourage you to look at their resources and reach out to Larry if you're interested in learning more about the resources that are available. So in thinking about broadening our workforce, another very innovative area has to do with expanding the workforce role for community groups. And the idea here is to build competencies in naturally occurring communities and community groups, and also to teach behavioral health providers to work with those groups. This is an intervention that's been very common in prevention and in the areas of substance use and rural health. Perhaps its most prominent application has to do with the development of anti-drug coalitions in communities. The innovation that I've highlighted here is from CADCA, an organization that has really pioneered training community groups in a competency-based way on how to form a coalition, how to assess a community's needs, and how to address those needs with interventions and evaluate the impact of those interventions. So I would direct you to look at some of the CADCA resources if you're interested in this idea. The third way in which we've been expanding the behavioral health workforce is by expanding the roles of health and social service professionals who are not in the behavioral health field. As you likely know, there's been a lot of work with primary care providers in implementing integrated care that teaches them to be able to screen and assess and do brief interventions with individuals presenting in primary care settings who happen to have behavioral health problems. We have had a lot of development around screening and brief intervention techniques. There's also been work on co-location and consultation and referral models, though those have proven to be less effective than truly integrated care approaches. A lot of the screening and brief intervention has been focused on training emergency department personnel to be able to recognize behavioral health problems that present in emergency rooms. And with the Sandy Hook tragedy, the killings that occurred here in Connecticut some years ago, there's been a national effort to greatly expand the training of teachers and other school employees as first responders around mental health issues. There are lots of resources here to draw on. SAMHSA has funded and HRSA have funded the Center for Integrated Health Solutions. And this is one of their web pages on workforce development. Highlighted on the right here are the core competencies for integrated behavioral health and primary care that are useful for training and both pre-service and continuing education. Those are competencies that my colleagues and I developed for the center about 5 or 6 years ago. Other places within this website have job descriptions, sort of ideal job descriptions for integrated care environments. Also highlighted here are some of the expert resources and youth mental health first aid, which has been the youth aid model that's been most prominently disseminated since the Sandy Hook tragedy. So we've talked about expanding the concept of the workforce, and I want to move on now to look at the sort of second bucket of objectives, which has to do with strengthening what we think of as the traditional workforce. And the first of those goals in that bucket is to focus on recruitment and retention. These are seemingly simple ideas, but there are many different objectives that we have here in this particular area, and that has to do with expanding the workforce by bringing people into the behavioral health field in general. There's initiatives to bring people into specific professions. There are similarly initiatives to bring people into specialty areas, such as working with child populations or older adults. We have the challenge of bringing people into or keeping them in geographic locations, often sort of rural areas where recruitment and retention can be difficult. We have the specific challenge of recruiting and retaining individuals in faculty roles. The crisis in nursing, for example, has been driven in part by the difficulty of finding enough faculty educators so that educational programs could expand. And then the challenge you'll be most familiar with is recruiting and retaining people in specific behavioral health jobs at the direct care, supervisory, and managerial levels. And then across all of that, we have the challenge of trying to diversify the workforce, creating more diversity of all types, not just racial and ethnic, cultural diversity in our workforce, which tends to be still sort of predominantly Caucasian. This is a vision I have for recruitment in our field. These are young children signing up with their letters of intent, their applications to work in our field. While I offer that in jest, it's pretty well known from research that if you want to shape someone's ideas about a career, you must begin very early in their course of their lifetime. And this is what the science researchers found out in terms of interesting young individuals in entering scientific careers. We have a number of states, California and Nebraska, that actually have educational initiatives that touch high school populations and educate them about mental health professions. In contrast to this, this more characterizes the models that we use in behavioral health, which are referred to as catch and release. So we spend a lot of time finding people for jobs, but we have fairly high turnover rates. And so having invested in the effort to find them and orient them, bring them on board, we sort of lose them back into the workforce as a major issue that we need to increasingly confront in mental health. If you look at the research, you can find turnover rates as high as 73% per year. And I've had organizations that I've worked with where the turnover rate has been as high as 150% per year. Not completely sure on my math here, but my initial calculation was that this would be equivalent to full turnover in the organization every 9 months. So pretty dramatic picture for some of the organizations, and particularly for direct care non-degreed workers at the front lines of the mental health system. If you dig a little deeper into the nature of turnover, a study by Wiltman in 2008 chose this way to look at turnover. 57% of the people leaving the organization had resigned. 12% had been terminated. So there our question would be, what was the recruitment of this person? Did we do a good job sort of bringing them into the organization? But Wiltman also decided to capture the percent that stayed within an organization but had been reassigned via transfers. And that was 29% in a given year. And this last bullet here highlights something that is something that everyone should know, which is that job reassignment within an agency can be very disruptive and has been shown to disrupt the fidelity to evidence-based practices. So if you have a member of your workforce and you teach them an EBP and then reassign them the expertise that they had for that particular role, working with that particular population is often disrupted. When we talk about recruitment and retention, everybody wants to focus on salaries. The best data that we have is from 2011, done by the National Council. You can see here that the salary for direct care non-degreed workers was very low, probably not what we would consider to be a living wage. Below that in the left column here, you can also see that average salaries for a graduate degreed counselor varied significantly by what is likely the economic health of the organization. So addiction outpatient residential programs had the lowest salaries, and FQHCs, which have, these are federally qualified health centers, have among the highest reimbursement rates for mental health services, and in turn, the highest salaries for graduate degree counselors. Another interesting finding was that behavioral health social workers working in a health system, for example, were making on average $5,000 less than comparably trained social workers that were perhaps working on a medical unit. And the finding that they like to highlight, the sort of catchy finding, was that these social workers in general were making less than a fast food manager at the local fast food joint, despite the fact that advanced education and was not required for those managerial positions in the restaurant industry. Everybody thinks about money as the recruitment and retention driver. This quote from Lee Branham, who does research in the business industry, says most employers believe that workers leave jobs for money, but few workers actually do. That generally appears to be true with the exception of employees who are making very, very low wages. They may move jobs for slight increases in order to better their position, given how much they may be struggling to cover their living costs. So what does Lee say people leave for? What are the reasons? And these are his 7 hidden reasons. The job or workplace is not what they expected it to be. There's a mismatch between the job and the person. There are complaints that they get too little coaching or supervision or feedback, that there aren't enough opportunities to grow, that they feel devalued and under-recognized, stressed from overwork and work-life balance. And the last here, the loss of trust and confidence in senior leaders. My colleagues and I have delved through the literature in mental health and have found these other reasons cited for the departure, the turnover rates, high caseload sizes, the impact of vacant positions, which put a greater burden on the people still in the organization. Mental health workers sometimes complain that their roles are not adequately clear or defined. The lack of varied work opportunities, a work environment that does not have supportive teams. Supportive teams are something that seem to be quite valued by workers in our field. And for supervisors and managers, there's a lot of evidence that some of them are assigned a very high and unreasonably high number of individuals to supervise. And in addition to that, often have direct care workloads as well, which might take up at least half of their time. So this is another factor that can lead people to part an organization. So in terms of the solutions and the resources that are available, SAMHSA funded the development of a recruitment and retention toolkit. This is available to you at no charge at the web address listed below. And it lays out an approach that involves the steps here in which you build a plan, you focus on recruitment, you focus on how you select people that apply, you improve your efforts at orientation or onboarding, and then offer more training, supervision, support, recognition, and career development opportunities. The beauty of this is if you follow this kind of model, you in essence are creating not just a recruitment and retention plan, but a workforce development plan for your organization. Another innovation here in this area on recruitment and retention is a small company called Ocumetrics. They were developed by a mental health association, this one, Mental Health America of Franklin County in Columbus, Ohio, funded by the Ohio Mental Health and Addiction Services, which is the state agency in Ohio that oversees mental health care. And they have developed a model for coming in and assessing the workforce using standardized survey instrument. They then engage the workforce in a process of focus groups and bring back to management a report that shows where your workforce ranks on a variety of dimensions compared to the workforce in other organizations. And those are tied to a lot of recommendations that they then offer about where you should focus your attention to improve your recruitment and slow the departure of individuals from your organization. I represent the Annapolis Coalition, and this past year with support from the Great Lakes Addiction Technology Transfer Center and the Central East Mental Health Technology Transfer Center, we've launched recruitment and retention learning collaboratives in the states of Maryland and Ohio. Organizations compete to participate. They then create small change management teams that spend a day with us learning about best practices in recruitment and retention. They begin to develop and then go on to implement a recruitment and retention plan tailored to their needs. And we provide them with ongoing technical assistance individually, and we bring them together for collaborative conference calls, all agencies together to talk about their successes and the obstacles and challenges that they've had in improving their recruitment and retention practices. So we talked about recruitment and retention. The next has to do with, the next goal has to do with improving training, making it more relevant, making it more effective, and making it more accessible to individuals in the field. The basic model here is there's a big push to identify competencies for training and then build and tie curriculum to those competencies. We're learning a lot more about evidence-based training methods, effective training methods. We have increasing opportunities to use technology to assist in instruction. The area and art of assessing competencies is growing pretty rapidly. We have a dire need to make sure that all members of the workforce have co-occurring competencies in both mental health and in addiction, since those two conditions more frequently than not occur in individuals that are presenting for our care. And we have a long overdue need to provide much greater training to the direct care paraprofessional workforce at the front lines of our system, which usually only get a day or two of training on the job for their very challenging roles. Another famous educator said that our approach to education is about as effective as having an educator, pictured here standing in an upper floor window, shouting at the students, pictured here walking on the sidewalk, try this, try that we throw out ideas to them, but we do not adequately engage in true competency-based, true skill and performance-based development of our workforce. It raises the question about whether we're really providing training to individuals or whether we're just exposing them to ideas. And my thought about that is what we're mostly engaged in with many of our educational efforts is what I call, is creating what I call rhetoric-informed care, in which we teach people a little bit about a lot of things. So they have heard and could possibly mention things like person-centered, consumer-directed, family-driven, recovery and resiliency-oriented, strength-based, trauma-informed, gender-specific, time-limited, co-occurring, culturally competent, evidence-based, transformative, preventative, wraparound care, but may have only surface-deep knowledge about what these concepts mean or how to apply them in their daily practice. There's a fascinating literature on effective teaching strategies, and it teaches us that there are no magic bullets. There's not a single thing that you can do that will guarantee that someone will take the knowledge that you give them and be able to apply it to practice. But what it does show is there are a whole bunch of interventions, and each one has a small effect. And the more of these you build into your educational approaches, the more effective your education of the workforce will be. So we know that interactive sessions in trainings are much more powerful than didactic trainings. We know that academic detailing or outreach visits, brief visits to a setting to coach them on a particular practice has an effect. We know that giving people reminders or auditing their work or their charts and giving feedback on what they're doing has an effect. The use of opinion leaders involves finding people in an organization where training has occurred who are revered and respected and engaging them in the process of encouraging others to adopt the practices that you're promoting through your training. We know that we can change what workers do by working through the patients or consumers. So if I give information to consumers about available vocational services, that may be as effective in increasing use of vocational services as giving the information to the staff. And lastly, social marketing is a fancy term for the notion that if we want something to be adopted, we must engage in a marketing approach that convinces our workforce that this is a valuable thing for them to learn, and understands what their reluctance may be, understands and addresses what their reluctance may be to adopt these these new practices. An interesting fact is that research also shows that if you show people pictures of brain scans while giving them information, they're more likely to believe that that information is true, that you've taken your information from brain research. So I encourage you to stare at this slide for 1 or 2 seconds so that you will increasingly believe the information that I'm providing here to you today. There are other relevant methods for teaching and for changing behaviors. Implementation science is the area of work that has tried to perfect approaches in which we not only teach our workforce, but we change the organizations in which they work, which often, unfortunately, sort of block or defeat efforts of the workforce, even when trained to engage in new practices. Many of our organizations look like the Escher drawing that's pictured here on this slide. And the basic point, again, is you must work with the organization and create organizational change in terms of changing worker knowledge in order to be successful in changing the performance of your workforce. I mentioned the learning collaboratives that we're doing on recruitment and retention, where you bring different organizations together to learn and then build plans for their organization. So these are quite common approaches. The ECHO model brings members of the workforce together to learn about a specific practice and then allows them to stay connected through teleconferences that are case conferences in which they can get ongoing consultation about their application of the work. And there's been a resurgence of interest in the practice of coaching, where individuals get intensive sort of guidance and support, typically around the implementation of a certain practice or around becoming better problem solvers in the day-to-day work that they do. Distance education has become very powerful in our field. This is an example of 2 online MSW programs. So you can take a shorter program, the one pictured on the right, if you already have a bachelor's in social work, and a longer program online if you're coming with another degree. This particular program out in California was funded in part by the federal government as a startup. And you'll notice the words below talk about the focus of the program on not only expanding the program's historic strengths, so this is sort of traditional social work, but also emphasizing early intervention, prevention, wellness, leadership and collaboration, core competencies, and implications of new findings in neuroscience. So this program is really stepping out and trying to be at the vanguard of sort of innovation and making their graduates highly productive and relevant to the current market that most employers are providing services in. Another initiative attempting to grow the workforce is in Missouri. The state of Missouri, through its Department of Education and I believe through its Medicaid arm, have created a track so that individuals can get Associate of Applied Science in Behavioral Health Support over 2 years, and are eligible to provide services in positions that were previously only eligible for reimbursement through bachelor's trained staff members. And there are lots of these training programs available at the different community colleges now in Missouri. We hear a lot of complaints at the interface between academia and employers. The employers are often dissatisfied with the professional preparation of graduates, saying they were not prepared for the real world. And educators who are very innovative are often dissatisfied with the lack of best practices in the employer setting. So if they train a student in an EVP and that student goes into a community practicum, they may not see that type of EVP or other EVPs in practice. We unfortunately see employers decreasing the number of students or interns that they take into their settings because of restrictions on the intern's time, the burden of having a student, and unfortunately many organizations have less staff availability to supervise students. But the real tragedy here is that I think many employers fail to see the value of student placements as a recruiting strategy. That old adage, to know us is to love us, is very true in the sense that students who train in organizations often become quite fond of them and can be a major pipeline for new recruits in your recruitment efforts. I want to just talk briefly about an evidence-based and promising practice model of in-home treatment. This was developed in Connecticut to address the absence of individuals trained to work in our large in-home treatment system for kids who were in trouble with the legal system. And Elizabeth Kanata, pictured here on the left, a psychologist who developed a 14-session graduate level course and a very comprehensive instructor toolkit to go with that. There was a 26-hour faculty fellowship that was created that faculty would go through in order to learn how to deliver this course. And she arranged a system of guest presenters made up of providers of in-home services and families who had received those services to go to the colleges and teach some of the sessions. And then offered a certificate of completion for students who went through this particular course. This data is about 9 months old here, but to date, or as of 9 months ago, Elizabeth had trained 32 faculty fellows across 14 graduate programs in 9 universities and 3 states. Those other states are contiguous to Connecticut. 3 of the universities or graduate programs made this a required course because it addressed their accreditation need to demonstrate teaching and evidence-based practices. It's been a regular elective in 8 programs. Over 600 students have completed the course, and families have felt very empowered through this experience as educators, and the students rate family and provider lectures as the sort of best part of this educational experience. I never thought this would work. Academia changes slowly, and so we've spent a lot of time figuring out why was this so successful. And I think there's some key lessons here. The resources that were created are comprehensive and very practical. We focused on faculty development in this Connecticut initiative, really teaching people how to be able to teach the courses. The alignment of graduate program needs from an accreditation perspective made it very palatable to the educational institutions. Small financial incentives were offered for startup to the faculty and their graduate programs. The curriculum was meaningful. The provider and family involvement really attracted and resulted in the high praise from the students. There was a lot of social marketing involved, and this training aligned with job opportunities that existed in the marketplace. I mentioned the dire need to train direct care workers. There is a freely available service online called the Roadmap of Core Competencies for the direct service workforce. These are competencies that you can use to guide your training of this frontline workforce. We also have some competencies that are available online developed in Alaska. These were cross-sector competencies addressing mental health, substance abuse, developmental disabilities, and long-term care. Part of Alaska's initiative to strengthen the frontline workforce in their state. A 6th area of focus in strengthening the workforce has to do with leadership and supervisory development. A core need here is to improve an organization's supervision policies, standards, and support, to identify the competencies you're going to teach, and then to have curricula and programs that are the bedrock of sort of ongoing leadership development that starts with supervision in your organization. And all of those steps make succession planning possible. An example of an innovation here, something the Annapolis Coalition cited as an innovation a number of years ago, was the leadership program in Aurora Mental Health Center outside of Denver. They allowed staff to, or invited staff to apply for this leadership experience, which involved spending 3 days over a long weekend together, being educated about leadership principles and quality improvement principles, and then also having guest lectures from local leaders about their perspective on the concept of leadership. Those would be people like the superintendent of schools or the police chief that would come in and share their ideas with the Aurora Mental Health Center staff. Participants in the initiative then engaged as a group on a quality improvement project for the organization over about 9 months, and presented the outcome of their work to the agency's leadership and any other staff that wanted to attend at a summative meeting of the leadership program. It's been a few years since I've talked to the Aurora folks, but at the time that I did, they were spending about $6,000 a year on this initiative, and staff hotly competed to get into this initiative. And one of the things I found most interesting is that leadership of the agency felt like it really changed and moved staff from sort of a one-down, sort of whiny feel about the organization to feeling more ownership and control of the organization, no matter what level they worked in the hierarchy of the Aurora Mental Health Center. There's been a lot of work on supervision. Here at Yale, we've developed the program on supervision, and its essential ingredients are built around an implementation science approach. So we focus on consulting to organizations and helping them change their supervision policies and standards, making them stronger, and then move to the staff development piece, working at all levels of the organization to train the 4 classic functions, to train best practices in the 4 classic functions of supervision, which are administration, quality, ensuring quality, professional development, and 4th, support of the workers. These are what we call consultations and conversations, in which we bring in best practices, but also facilitate conversations in which participants share their best practices with others in the room, which has been a very powerful approach. In the addiction side, the addiction technology transfer centers have clinical supervision courses. You complete some of these online as a precursor to being able to participate in the network's face-to-face trainings. The ATTCs have been very strong in the supervision areas, and in terms of publicly available resources, these are some of the best that would still have great relevance to your work in mental health. So moving on to some of the structures that we need to support the workforce. Organizations desperately need to have adequate human resource and staff development capacity. We argue that every organization should have its own workforce development plan as part of its organization, and develop in data-driven quality improvement on workforce issues, just as we do on overall quality of care. There are lots of opportunities for using information technology to support training and workforce activity and activity tracking, and a strong need to strengthen electronic medical records to decrease the paperwork burden, which staff almost uniformly describe in our organizations as variable, redundant, or purposeless reporting. So there are a lot of controversies about electronic medical records, but they provide an infrastructure that in many ways can be quite helpful. This is my image of the impact of paperwork burden on staff productivity. Just the notion here that sometimes people drown so much under the burden of the documentation that they have to do that it's very difficult for them to really get any traction in their basic functions. Some other structures that exist. This is the Behavioral Health Education Center of Nebraska. It is a center funded by the state legislature for the sole purpose of promoting the recruitment and retention of a behavioral health workforce. They have done an enormous amount of work in this area, and the intervention pictured here is the Ambassador Program, which is one of those programs that reaches out to younger individuals, and I believe this is primarily high school, to get exposure to behavioral health careers. Goal 8 is about evaluation and research. A couple years ago, the federal government funded the Behavioral Health Workforce Research Center at the University of Michigan, and we're now getting better data about the workforce across the nation. The most important thing that I would like to emphasize for you is if you embark on any kinds of initiatives or interventions related to improving your workforce, to do your best to document the processes that are using, to evaluate even informally the impact that they're having. And if you have something that you think is worthwhile, to do your best to sort of disseminate that information to others and to share the wealth in that way. The final goal around structure has to do with our financing structures. We know sort of what the dynamics are here with when we have underfunded services, and that is that if the resources are not there, the workforce size is constrained, and we simply hire less people. Wages and benefits become suppressed, and then our caseloads, our worker burden, burnout, and turnover increase. And overall, we know that the economic benefit of pursuing a career in mental health has declined over the years. And that makes recruitment more challenging. But there are solutions, and this is a very recent and very bright one. So the state of Maryland recently passed an increase in the minimum wage. And the behavioral health organizations, through their lobbying group, lobbied hard and achieved a 22% increase in behavioral health funding over a period of 6 years to cover the projected increased cost of the minimum wage. The governor, of course, vetoed this, but I'm happy to report that the legislature overrode the veto, and this 22% increase stayed in place. The other major thing that happens in our country around financial support is the National Health Service Corps. This provides loan repayment funds and other types of funds to individuals who agree to work in underserved areas. There's a complex process for becoming qualified as an organization to participate in this program, and there are more agencies looking for participants in the program than there are participants. But that being said, for the right organization at the right time, this can be a powerful way to attract somebody or keep somebody among your own workforce. The document shown here is this sort of guide for community behavioral health on the National Health Service Corps is available on the Center for Integrated Health Solutions website, which I highlighted for you earlier. So just a concluding thought. I used to say that workforce was like the elephant in the room, meaning the thing that was always there, sort of always in our way in terms of being successful, but something we never talked about. And then I saw this cartoon in the New Yorker not too long ago, this lovely couple sitting by their elephant saying, actually, it's all we ever talk about. There's a lot of discussion about workforce these days, and the challenge now is to actually take action. I encourage you to do what I call advocate and act. If you believe that mental health services are underfunded, I encourage you to advocate with your local, state, and federal politicians and agencies and whatever to keep advocating for more and better resources for our field. But at the same time, it is imperative to act. There are many things that you can do to strengthen your workforce with the resources that you have available to you today. So advocate and act is my encouragement to you. If you have questions for me, you can email me at this address. You can look at our Annapolis Coalition website, and there is a place where you can sign up for our e-newsletter about workforce issues. We issue this no more than 4 times a year, so it's not something that will overwhelm your inbox. The slides, handouts, and the recording from today's presentation will be available online at the MHTTC website in the near future so that you can access those as well. And if I'm successful here, I'm going to turn this now back over to Heather.
Thank you, Michael. Can you hear me?
Yes, I can.
Great. So I wanted to give you a big thanks for the great presentation and ask if in our remaining few minutes there were any questions. If you have questions, you can type them in the chat or you can unmute yourself and ask away. So, Michael, I did receive a question privately to me through the chat that asked if you could talk for just a minute about specific strategies for recruitment and retention.
Wow, that's a big question.
Or key resources for recruitment and retention.
Well, so the planning document that I highlighted from SAMHSA is the sort of largest publicly available document online. It's sort of a strange web structure that you have to sort of make your way through, but there are hundreds and hundreds of resources that are available to you within that. Many of the recruitment and retention strategies that are available to us are really not unique to behavioral health or really even unique to healthcare. And they start on the recruitment side of being more intentional about thinking about where you post jobs, and in addition, creating more of a presence for your organization in the community so that people think of your organization when they think about potential employment. And there are increasingly lots of social media opportunities at very low cost to increase an organization's presence. Once you find people, there is an opportunity to be intentional about selection. We encourage the use of things like job shadowing, where a prospective candidate spends a little bit of time in the organization observing the work, particularly at the direct care level, so they can understand what the work might entail. Beyond that, being more systematic about not just an orientation, but a thorough onboarding process where you really welcome an individual and convey the value the organization places on them and give them a thorough introduction to their work. And then from there on, there are the training and supervision and career opportunities that are the foundation of, I think, what keep people happy and make them feel like they have an opportunity to grow their jobs and their careers within the context of your organization.
Excellent. There's a question in the chat. Can you speak for a moment about recruitment and retention of local workforce in rural and underserved areas? Many localities struggle with programs that incentivize individuals to come work in an underserved areas, like as, for example, through loan forgiveness, but as soon as their obligation is met, the professionals leave. Many localities want to focus more on a grow our own approach.
Right, so I think that the grow your own approach is a fabulous model. And for those that are not familiar with it, it's the concept of finding individuals who live in the area who are what we call place committed. Like they live in this area, this is where they grew up, this is where they want to stay. And so the challenge to growing your own is that you must have a career ladder that's available to them to climb. So you generally need to have some entry-level positions that they can move into and some combination of additional opportunities for education and job advancement so that they can continue to grow. I've been working up in Alaska for about 10 years, consulting up there, and they do a remarkable job with this. Working as a state, they've systematically been filling some of the gaps in their educational system so that people could start at the bottom rung of the ladder and sort of move forward. The loan repayment programs are can be effective. There is this sense that people tend to leave after a period of years. But I think one of the things I learned about recruitment and retention from the developmental disabilities folks, the professionals, is that for frontline developmental disabilities position, I think the average length of job tenure is under a year. And they expect that and they work with that, meaning that if you're going to have fairly high turnover, you have to really ramp up your systems to be effective at finding your next worker And you also have to become very effective at improving your onboarding process so that you can bring people on board and get them working fairly quickly. So I think we all share the ideal that we'd like to find people and have them stay within our organizations for a long time. But I think we also have to practice acceptance of the fact that turnover is going to be significant, and that means we have that challenge of becoming really good at finding people and really good at bringing new people into our organization and getting them up to speed fast.
Excellent, thank you. So we're going to close out the webinar now. Again, a huge thanks to Michael Hoge from the Annapolis Coalition for this great presentation. You can catch the presentation and the slides on our website shortly, and it's mhttcnetwork.org. Please also visit the website to find your local MHTTC Regional Center. There's a section there in the upper left corner that says Your Center, and if you click on there, you'll be able to figure out which regional center you have, and check out their webpage and see what technical assistance and training resources you can get access to. So thanks again, everyone, and hope to speak with everyone soon. Thanks for the conversation.
Thank you all. Be well.